Okay, let's unpack this. Welcome to the deep dive. Today, we're really digging into the subtle yet significant world of pleural diseases. You sent over some fascinating materials, and we're going to use those today as our map. We want to uncover how radiology, imaging, helps us navigate everything from simple thickening to, well, the really complex malignant tumors, our mission. Absolute clarity on these often tricky visual clues.
It really is fascinating. Pleural thickening, we often see it as this kind of organized end-stage process from inflammation. And if it gets really generalized and quite gross, we actually call it a fibrothorax. Think of it like this tough armor around the lung. Problematic because it can really impair breathing.
And the causes. What usually leads to that?
Well, common culprits are usually a past history of empyema or tuberculosis. And like you pointed out from the research, seeing extensive calcification,
Right.
that strongly points towards those kinds of past infections.
It's amazing how much a subtle shadow can tell us, isn't it? So when we look at a chest x-ray for this, what are the first things we should really be looking for, those critical indicators for pleural thickening?
Absolutely. On a standard chest x-ray, you typically look for fixed water density shadowing. That just means it looks as dense as fluid or solid tissue, not air. And it's often in the dependent parts, the lowest areas where gravity pulls things down. Think the costophrenic angle, that little corner at the bottom of the lung field.
Right.
And if you see in profile, it looks like a soft tissue band, maybe up to 10 millimeters thick, running parallel to the chest wall.
That paints a clear initial picture. But what's truly insightful here is why CT becomes our go-to. X-rays give us that first broad stroke, sure, but CT, that lets us see the subtle 3D details, right?
Precisely. CT is definitely the most sensitive for picking this up. You'll often see the pleural thickening particularly clearly on the medial aspect of the ribs, the inside surface. And for a true fibrothorax, CT shows thickening greater than 3 millimeters. But also, importantly, it stretches a significant distance, usually more than 8 centimeters top to bottom, or craniocaudally, as we say.
Right.
Or more than 5 centimeters across laterally. These aren't just random numbers, they're key thresholds that really help us distinguish it definitively. And for something really unique, you can see this in images. A and B asbestos-related calcified plaques can sometimes show up with this distinctive holly leaf pattern on a CXR.
Holly leaf.
Yeah, exactly. Those crisp, kind of scalloped edges. Almost looks like a real holly leaf. It's a real telltale sign of past exposure.
Wow, that specificity with the measurements and the holly leaf, that really helps. Okay, so from that generalized inflammation, let's zoom in a bit. Let's talk about a different kind of growth, the localized fibrous tumor of the pleura. This one's interesting because, well, it often causes a stir, but is frequently benign and, crucially, not linked to asbestos. That's a big differentiator.
Yeah, it really is.
Yeah.
And radiologically, these have a very distinctive look, as you can see there in images A and B on a chest x-ray. It shows up as a pleurally based mass. It's usually well demarcated, maybe slightly lobulated. And here's a fascinating clue.
Yeah.
Sometimes you see marked positional variation.
Meaning it moves around.
Exactly. If it's pedunculated attached by a stalk, kind of like a mushroom growing off the pleural surface, it can actually move with breathing or changes in patient position. That's a really powerful clue, almost a signature for these benign tumors. Then on CT, it typically looks like a heterogeneous mass. It often enhances with contrast, but it's rarely calcified. And another key feature, these masses often form an obtuse or wide angle with the chest wall. That helps signal that it's coming from outside the lung itself, an extrapulmonary origin.
Okay, so we've covered the inflammatory thickening and the localized benign tumor, but what happens when the imaging clues start pointing towards something?
Well, something far more concerning. The real diagnostic tightrope walk often comes when we're trying to distinguish malignant mesothelioma from pleural metastases.
Indeed, those are the two heavy hitters, and honestly, differentiating them on imaging alone can be quite challenging. Mesothelioma, as you said, has that strong link to prior asbestos exposure. On an X-ray, you'll typically see irregular nodular pleural thickening, and it's almost always accompanied by a pleural effusion fluid buildup.
Now, when we look at the CT images for malignant mesothelioma, what you'll often observe is circumferential nodular thickening. It's usually thicker than 1 centimeter. And it frequently extends into the lung fissures or over the mediastinal surface. It can even invade the chest wall directly, sometimes showing areas of necrosis or tissue death.
Right. And then you have pleural metastases, which you mentioned are actually far more common, often coming from primaries elsewhere, like lung, breast, or lymphoma.
Precisely. And as you can see in the metastasis image on CT, these usually show up as multiple spots, multiple foci, though sometimes they present as diffuse tumorous pleural thickening that extends into the fissures, which can, mimic mesothelioma quite closely, again, often with an effusion, and the thickening itself is frequently lobulated, kind of bumpy.
So, what are the key signs on CT that scream malignancy for either condition?
Good question. Key signs pointing towards malignancy generally include circumferential involvement or involvement of the mediastinal pleura. Also, parietal thickening. That's the thickening along the chest wall itself greater than 1 centimeter. And lung encasement, where the tumor wraps around the lung. What's interesting there is, despite the lung being encased, you often see a relative absence of mediastinal shift. The tumor kind of fixes everything in place.
That's a critical detail.
It is. It suggests tumor rigidity. And while MRI can sometimes be better for looking at mediastinal or chest wall involvement in detail, the bottom line, radiographically, is that mesothelioma can be really difficult, sometimes impossible, to distinguish from pleural metastases just based on the images.
That idea that they can be radiographically indistinguishable is quite sobering. Does that mean imaging sort of fails us there, or does it just narrow the field, pushing us harder towards other tools like biopsy?
Well, I think it brings us right to the heart of the diagnostic challenge, doesn't it? When imaging alone can't definitively separate these two aggressive diseases, it really underscores that radiology, while incredibly powerful, is just one critical piece. It's part of a much bigger clinical puzzle. Often, it points directly towards needing that biopsy, needing that detailed patient history. So this raises an important question. How does understanding these distinct radiological patterns really deepen our appreciation for the whole diagnostic journey in these complex pleural pathologies?
Truly, it shows that every detail, every nuance in an image tells such a vital part of the story. It really invites us to look closer, doesn't it? And consider that whole complex narrative of disease.